Now it works. Well, okay, the first slide demonstrates our experience with the cardiovascular laser application in the 1064 wavelengths. With its low absorption in water, the photons are not absorbed by transparent or translucent tissue, such as the endo and epicardium. In myocardium, photons are scattered and, as a most unique characteristic, are selectively absorbed by the myocytes. This is seen on the right side. After frequent photon scattering in myocardium, laser lesions arise deep intramurally by friction between molecules, whereas the catheter itself is not heated up. It does not transmit heat. It is rather cooled by the saline irrigation fluid at room temperature. Thus, lesions are produced under normal thermic conditions. The video shows that laser application at 15 watt by using a flexible laser catheter demonstrates the stable catheter position and the short application times of 10 to 15 seconds. This means that the laser method as applied with this catheter is a low power, short duration ablation procedure. Here you see the lesion with its dipped and the shining lesion through the undamaged epicardium. This is only a dot of the catheter. This is not tissue vaporization. The lesion achieved by this video is shown here on the left, and it demonstrates that the lesion is transmural, homogeneous, clear-cut coagulation necrosis without tissue vaporization with crater formation. Left ventricular endocardial lesions achieved by endocardial catheter application shows the lesion shining through the translucent undamaged endocardium around this of the dotted circle. The arrows shows the assumed orientation of the catheter during laser application. In this series of slides, you see right and left atrial lesions shining through the translucent undamaged endocardium, and the spots are 8 up to 12 millimeters in diameter. So these are not point by point lesions. These are spot by spot lesions. Sizes and volumes of lesions produced in a thigh muscle model demonstrate a linear increase of lesions with the level of energy applied. There is no substantial difference between the 12 and the 13-20 watts of lesions induced, because there is a clear-cut difference between different time of application of the laser. And there is a unique side that this 1064 laser does not damage the endocardium or does not damage all these structures. And what we can see is that laser applications depend on the power set and the time of application. And so we see that the first pop occurs at 15 watt after 50 seconds of radiation. This means that below 40 seconds application, the 50 watt application can be considered as a very safe method. And in addition, we see there is no incidence of coagulum, so that a most unique characteristic of the laser is it is not thrombogenic. When you start the laser by application aimed at epicardial coronaries, that demonstrates that the vessel is conserved conservation of vessels demonstrate that the laser is not damaging the artery, the coronary vessels. Unique is the 1064 laser does not damage coronaries. This is a very important insight because the lesion achieved through the coronaries demonstrate that there is no damage of the intima and the media of the vessel, and the lesion created through the coronary is a clear-cut homogeneous coagulation necrosis. Differences of size of lesion is given by the coronary flow. If coronary flow is unrestricted, is not reduced, the lesion is smaller because coronary flow cools the lesion and dissipates laser energy in the vessel. During laser application, we see that the tissue is selectively touched. There is a clear-cut homogeneous necrosis, no thrombogenic, no arrhythmogenic effects, no coronary damage. Thus, the laser is a low-risk method of ablation. During laser application, high-density mapping displays a gradual dwindling, and this shows that His bundle recordings can be achieved only when the laser is placed upon the His bundle. If it is slightly dislodged to the right or to the left, the His bundle potential is lost. So this is very important with the inter-electrode distances to keep the catheter precisely upon the His bundle. And this is a high-density, high-resolution mapping achieved with a laser catheter provided with endocard electrodes at a distance of 2 millimeters between the electrode tips. During laser application, high-density mapping displays a gradual dwindling of local electrical potentials without electrical hum during this application. Thus, the gradual dwindling of potentials amplitude is seen from A to A1, and this occurs without electrical hum in the mapping electrograms. This is a unique characteristic of the 1064 laser light. It does not interfere with electrophysiologic monitoring principles. Thus, electrical potentials are abolished after less than 5 seconds, and even more importantly and most unique is that timely laser stop is saving the esophagus. You see here the endocardial posterior wall ablation and the created lesion and the undamaged esophageal wall. How to control the thermal effect on the esophagus? Temperature sensors were placed behind the left atrial posterior wall, showing a 3 to 5 second time difference between permanent abolishment of electrical potentials and esophageal sensor signals. Thus, timely stop of laser 3 to 5 seconds after permanent abolishment of potential amplitudes, laser lesions will stay limited to the myocardial wall without collateral damages to adjacent anatomical structures, including the esophagus. Correlation coefficient found was 0.9. Example of potential amplitudes are seen here in vivo lesions. They show that if the potentials are not completely abolished after 20 watts, or only attenuated 70%, the lesion is not transmural. If it is abolished and the laser application is stopped after 4 seconds, the lesion is transmural. However, extending ablation time and radiation to 40 seconds and abolishment after 30 seconds, the difference of 10 seconds may produce a pop phenomenon, and this should be always avoided. Based on these insights, we have developed a HD laser mapping novel cardiovascular system, and it consists of a compact diode laser, a roller pump, and the catheter rhythmolase with its variants. All have trademarks, are unique device identification, are certified, and have a CE mark expired for the catheter. By using this laser system, you can choose with your languages and see what kind of language you will use. And then you have the indications for ablation. You can choose between thin-walled myocardial and thick-walled myocardium and transeptal puncture. If you choose one of these, you can see that with a thin-walled myocardium, pulse duration is 10 seconds and power is set at 10 watt. These are preset values, and you have but to start ready, and then you can ablate in thin-walled myocardium, e.g. ablation of atrial fibrillation. The radiation will stop automatically after 10 seconds, so that you are always on the safe side. If you choose thick-walled myocardium, the pulse time is 15 seconds and the power is set to 50 watt. At this time, you can see that you are on the safe side when applying laser applications to the ventricular walls. In case of transeptal laser puncture, you do not need cooling with a saline, and therefore we have a short pulse of 5 seconds and 5 watts power, so this will achieve a safe and instant puncture of the atrial septum. Cardiovascular laser access needs introduction set, e.g. the Agilis. The catheter shows the electrodes at the tip, which is transparent, and here you see the fiber tip, which is coaxially mounted in the central lumen of the head. And this is a catheter that is designed for cardiac arrhythmias, for Holcomb ablation, Chagas VT, renal sympathetic denervation, resistant pulmonary hypertension, varicose vein ablation, all in one, the same catheter. Photon scattering in the myocardium is the same with a catheter in vertical position or in flat position. The photons are always diffusely scattered, so that you see you can achieve transmural lesions regardless of catheter orientation towards the endocardium. Therefore, we can say that the catheter orientation is not a major determinant for lesion formation. If you treat the Holcomb, you can see that in case of the right side ablation, from the right ventricular side, the right ventricular septum is irradiated during the systole. This narrowing is the obstruction, and after treatment, the left ventricular systole shows a relaxed left ventricle with normal pressure in the aorta. There is no pressure gradient, just like before, where the pressure gradient is significantly. The other modality of treatment is renal and pulmonary artery denervation. You see that with this catheter you can achieve a tubular radiation at the length of up to 6 millimeters, and during renal and during pulmonary artery denervation, there is no lesion in the vessel itself. Only the nerves are selectively destroyed acutely and chronically. For the laser ablation of long-lasting persistent atrial fibrillation, we have performed applications in the right and left artery and the left atrial posterior wall until the electrical activity of the entire posterior wall was abolished. So denervation of this huge surface with overlapping lesions achieved a success rate of 96% without complications during a follow-up of 8.2 years. Patients are without medications, quality of life is nearly normalized, and successful redo procedures for AF was performed only in 2 patients, and the success, we assume, is achieved by the retrocardiac ganglion plexi modulation, which can be achieved only with these laser applications. For magnetic navigation, the catheter was provided with magnets at the distal end and shows that these magnets allow clear and successful magnetic navigation in the stereotaxis Niobe installation. For transeptal puncture, the catheter is provided with a push-click valve, which replaces the connector. And with this push-click, you can put it in an idle position and introduce the dilator in the pre-placed Achilles sheath. And when you have the orientation towards the septum, you can advance it with a first click for 2 millimeters and stabilize the position. If this is a correct position, you can, with a second step, advance to 5 millimeters and simultaneously start the laser and puncture the septum. This allows for a very safe and a very successful puncture in a site-selective position. We can conclude that with this unique characteristic, the 1064 nanometer laser has the potential for becoming an all-pervasive procedure. It is also unique for implementation of design to cost, for procedural homogeneity, for reproducible results, for standardized data quality, for evidence-based procedures, and opens a large field of research opportunities. Thank you for attention.